Hello friends, in this chapter let us now learn about the nephrotic syndrome. Okay, in the nephrotic syndrome, first the main features of nephrotic syndrome include, first there is proteinuria which is present for more than 3.5 gram per 24 hours, and we have hypoalbuminemia. Okay, there is hypoalbuminuria. So there are mainly 5 important factors. One, we have proteinuria, that is more than 3.5 gram per 24 hours. Then we have albuminuria or hypoalbuminemia. We will see that in a minute. Then there it is associated with edema, hyperlipidemia or lipiduria. Lipiduria or hyperlipidemia is also seen in nephrotic syndrome. So if you see about albuminuria, so this albuminuria can be divided into 3 main parts. So whenever the albumin is between less than 30 to 300 milligram per 24 hours, if the albumin is less than 30 to 300 milligram for 24 hours, then we call it as microalbuminuria. So this microalbuminuria is seen in early diabetes mellitus, early stages of glomerulonephritis, and early stages of essential hypertension. Then we have something called as macroglobinuria. Macroglobinuria is called when the albuminuria is more than 300 milligram per 24 hours, then we call it as macroglobinuria. Micro is 30 to 300, macro is more than 300 milligram per 24 hours, then we call it as macroalbuminuria. This macroalbuminuria is seen in multiple myeloma, postural proteinuria. It is seen in multiple myeloma, postural proteinuria, and congestive heart failure. Then if the albumin or proteins are more than 3.5 gram per 24 hours, then we call it as nephrotic range proteinuria. When the protein concentration or albumin is more than 3.5 gram, it is gram per 24 hours, then we call it as nephrotic range proteinuria. That is seen in minimal stage, all the nephrotic syndromes like minimal stage disease, okay, that like minimal change disease, membranous glomerulonephritis, membranoproliferative glomerulonephritis, focal segmental glomerulonephritis, diabetes mellitus, amyloidosis. In all these we have nephrotic range proteinuria. Okay, that is nephrotic range proteinuria. Then we have something called as nephritic range proteinuria. If the protein is just 3 gram per 24 hours, then we call it as nephritic range proteinuria. Okay, this is nephritic range proteinuria. So these are the main types of proteinuria based on the amount of albumin that is lost in the urine. Then if you see, the proteinuria can be divided into 2 types. Okay, we have mainly 2 different types of proteinurias. First we have glomerular proteinurias or tubular proteinurias. So if you see, first we will see the differences between them. Glomerular, as the name says, here the leakage of proteins is from glomerulus to the Bowman's capsule. Okay, that is glomerular. In tubular, there is problem or failure in absorption of proteins. In tubular, there is failure in absorption of proteins, is tubular proteinuria. Glomerular proteinuria is leakage of proteins from glomerulus to Bowman's capsule, is seen in glomerular proteinuria. Then if you see daily excretion, for glomerular proteinuria, daily excretion is more than 3.5 gram per 24 hours. If the daily excretion is more than 3.5 gram per 24 hours, then we call it as glomerular proteinuria. Tubular proteinuria should not be more than 2 grams per 24 hours. It won't be more than 2 grams per 24 hours in tubular proteinuria. Then if you see glomerular proteinuria, you have mainly albumin and globulin involved in glomerular proteinuria. In tubular proteinuria, we have beta 2 microglobulin, lysozyme or light chain immunoglobulin are involved in tubular proteinuria. In tubular proteinuria, mainly there are involvement of beta 2 microglobulin, lysozymes and light chain immunoglobulin are involved. Then in the albumin is to beta 2 microglobulin ratio is more than 1000:1 for glomerular proteinuria. It is 10:1 in tubular proteinuria. Then if you see Tom-Horsfeld protein is not raised in glomerular proteinuria, it is raised in tubular proteinuria. So this is about proteinuria. Okay, then we will see some important points in nephrotic syndrome. See, nephrotic syndrome is also associated with albuminuria, transferrin is lost in the urine, ferritin, cholecalciferol binding protein, ceruloplasmin, then antithrombin 3, thyroxine binding globulin. Okay, so all these are lost in the urine along with albumin, transferrin, ferritin, cholecalciferol binding protein and ceruloplasmin, antithrombin 3, thyroxine binding globulin. So all these are lost in urine in nephrotic syndrome. So one thing which is very important in nephrotic syndrome is there is loss of oncotic pressure in there will be edema. Okay, why is there an edema? Because of loss of oncotic pressure, that is whenever the albumin is lost, so obviously there will be less proteins in the blood, so there will be loss of oncotic pressure and that will lead to edema. Or it can also be due to defective tubular excretion, that is the water and sodium are not able to be excreted properly, so as a result there will be retention of sodium and water, that is called as overfill theory of nephrotic syndrome, that is overfill theory of nephrotic syndrome. Then we have second, which is loss of antithrombin 3 and protein S. This loss of antithrombin 3 or protein S is seen whenever there is loss of antithrombin 3 or protein S, or there can be the antithrombin 3, protein S and protein C are the compounds which prevent coagulation, right? Then there can be also increase of some clotting factors like fibrinogen, factor 5, factor 7, factor 8, factor 12 and factor 13 are also increased, and there is decrease in plasminogen. So overall, if you see, by balancing all this, there is hypercoagulability is seen in nephrotic syndrome. Okay, though there is loss of antithrombin 3, protein C and protein S which prevent thrombosis, but still because of increased fibrinogen and coagulation factors, it causes hypercoagulability. It also causes increased lipoprotein synthesis. So as a result, there will be hyperlipoproteinemia or hyperlipidemia, that is increased triglycerides, increased VLDL and increased total cholesterol are seen in nephrotic syndrome. You will also see renal venous thrombosis. Renal vein thrombosis is most commonly seen with membranous glomerulonephritis. Renal vein thrombosis is also seen, which is most commonly with membranous glomerulonephritis. There is increased susceptibility to infection. There is loss of transferrin. Because of loss of transferrin, iron mobilization is affected, thus causing microcytic hypochromic anemia. Then there is also loss of cholecalciferol binding protein. So as a result, there is hypocalcemia. There is also loss of thyroxine binding protein. Thyroxine binding globulin is also lost. So there will be decreased thyroxine. So these are the clinical manifestations of nephrotic syndrome that include hypercoagulability, hyperlipidemia, renal vein thrombosis, increased infections, microcytic hypochromic anemia, hypocalcemia and decreased thyroxine. So if you see hypoalbuminuria or hypoalbuminemia is due to the loss of albumin in urine. Whenever there is loss of albumin in urine, you have blunted compensation of the liver. Liver tries to compensate it, but it could not do it properly because of high loss of albumin in nephrotic syndrome. And as a result, there are some types of nails called as Murke lines on nails are seen. Mushke lines lines are seen over the nails. And there is also loss of muscles, proteins and amino acids are seen. Then we have lipiduria, right? Lipiduria produces oval fat bodies. So these oval fat bodies under polarized microscope, these are seen as Maltese cross deposits. Okay, lipiduria produces oval bodies which under polarized microscope they are seen as Maltese cross deposit. I will show you this deposit just in a minute. Okay, then what is the most common nephrotic syndrome in the children? Minimal change disease is the most common nephrotic syndrome in children. Most common nephrotic syndrome in adults is membranous glomerulonephritis. most common systemic disease causing nephrotic syndrome is diabetes mellitus is the most common systemic disease causing nephrotic syndrome. Then we will learn few points about HIV associated nephropathy or collapsing nephropathy. So this HIV associated nephropathy or collapsing nephropathy, it is an aggressive form of focal segmental glomerulosclerosis. I will show you the focal segmental glomerulosclerosis also. This in HIV associated nephropathy, you will see the swelling of visceral epithelial cells is seen in biopsy. There is swelling of visceral epithelial cells, collapse of glomerular tuft is seen, and there is also dilatation, microcystic dilatation of renal tubule is seen. Sometimes there is also pseudocrescent with podocytes are also seen. Okay, so this progresses to end stage renal disease. So here we should give antiretroviral therapy. I'll show you the picture in a minute. So causes of this collapsing nephropathy include: one, I have already told you that HIV is one of the cause of collapsing nephropathy. Other causes include usage of heroin, palmidronate, parvovirus B19, interferon alpha. So causes of collapsing nephropathy are HIV, heroin, palmidronate, parvovirus B19 and interferon alpha are the causes of collapsing nephropathy.